Welcome to the SCR Connections July webinar. Thank you everyone for joining us. It is my pleasure to introduce our guest speaker. Chanin Wendling is the Associate Vice President of Informatics at Geisinger Health System in Pennsylvania. She has developed key strategies that leverage mobile and portal technologies to drive digital patient engagement and facilitate the provider's ability to deliver quality patient care. Her mobile tech projects include smartphones for providers for secure text messaging and EMR access, text message appointment reminders and diabetes management, iPads to collect patient data and drive patient engagement, mobile apps for colonoscopy and lumbar spine surgery, and ebooks and patient engagement packages through iTunes University. Her portal projects have included expanding patient access to clinical data, using the portal as a conduit to gather important patient data for areas such as medication reconciliation, depression screening, and asthma management, using the portal to help patients prep for a visit so that exam room time can be focused, and providing a portal for referring providers to stay connected to their patients' care at Geisinger. Her current efforts focus on the ability to deliver personalized health care, tailoring care based on the patient's communication preferences, behaviors, and motivations. Okay, without further ado, I'm going to let her get started. Welcome.
Thank you, Brian. Appreciate that introduction. Happy to be here and, be able to tell you a little bit about where we're going in terms of personalized care. As Brian mentioned, you could tell from the description, I am not a librarian, but from a sort of weird happenstance, I do actually have reporting responsibility for Geisinger's libraries at the moment. I sit in a place called the Division of Informatics, and we had some structural changes. The library used to report up through IT, and there were some changes made based on retirement and a new CIO, and people started to look at this and said, the library really doesn't belong in IT. Where does it really belong, where it can best serve the organization? And it needed to be in a division where really its function got to be shared and, it got to serve the multiple communities around Geisinger. And so it ended up coming to the Division of Informatics and under my responsibility. So for the last a little over a year, I have had the pleasure of actually learning about how a clinical library functions and getting more involved. So what I wanted to do today is start with just a little bit of background about Geisinger's library, just so you have that information and you can sort of put that in context. And then really the bulk of what I want to talk about is our approach for patient personalization to give you an idea of where we're going. And then, I just wanted to throw out some ideas on how the library function could really impact this direction. And maybe there's some discussion about that. And as Brian said, then we can go into questions and happy to talk about either our library or the patient personalization. So just to give you a little bit of background about Geisinger, if you're not familiar with us, we do operate primarily in central Pennsylvania. We did merge with a health system in New Jersey called AtlantiCare. So we've expanded our footprint a little bit, but from a care perspective, we're primarily in the Pennsylvania area, as you see, 12 hospital campuses, et cetera. We do have a health plan, Geisinger Health Plan, and that operates in multiple states. So in addition to Pennsylvania, we do have New Jersey, Maine, West Virginia, so that has a little broader reach. And then very recently, we just reached an agreement to work with the Pennsylvania Commonwealth School of Medicine, and officially in January, we became the Geisinger Commonwealth School of Medicine and incorporated that function. So we now have an academic part to our overall organization, and we just started some of the 3rd and 4th year students down in our Danville, Pennsylvania campus to work with our clinical teams. And so very new and interesting development for all of us to have that function. It also has implications for our library. The decision was made that we definitely want to consolidate the library approaches, and they're going to end up being under the School of Medicine's direction. So we've actually just engaged consultant to help us look at our overall structure and what might make sense for this combined organization. So turning to a little bit more of the library, as you can see up in the red, the Geisinger Commonwealth School of Medicine is our most recent, and we're trying to figure out how to integrate the functions of a clinical library with a School of Medicine library. We also have a number of physical sites. Our main location is the Geisinger Medical Center, and we have I would call a large library presence there these days. We then have smaller libraries in a number of our other hospitals at Lewistown, at Holy Spirit, and two in the Scranton-Wilkes-Barre area, the Geisinger Community Medical Center, and Wyoming Valley. So we do have a number of librarians and library specialists that serve our clinical teams in these various sites. And again, we're starting to integrate with the School of Medicine. In addition, we do have a community health library. This is the library for the patient and their families. We only have one community health librarian. I would argue that would love to see that library function have some more resources and more available to our patients. That librarian is located in our Danville campus, does take online requests from throughout our system, but most of the in-person activity is going to occur in our Geisinger Medical Center in Danville. And this person, she's pictured there in the black, Megan Evans, also works in the hospital setting and does rounding with patients. And so we'll go to various inpatient units and talk to the patient and their family and try and help them get the information they need to address their care questions. So she's actually done, in 2016, talked with about 1,681 patients. It's not about, that's precise. And she's actually gotten 495 consumer information requests from those. In addition, we have a program where we give iPads to patients on a number of inpatient floors. You can see the young gentleman working with his iPad. And that includes a connection to the community health library, so patients can request information there, and Megan will talk to the patients about that service, how to use it, et cetera. And so you can see at the bottom that, you know, the patients ask for another number of information, questions about their condition, better understand instructions, better understanding their condition. So those are the types of things Megan is getting when she rounds with patients. The bulk of our library function is around the clinical teams, the doctors, the nurses, the pharmacists, et cetera. And this is a screenshot of the library webpage that we offer for those folks. And they can come to this library, they can make requests. We've done a lot to better provide resources in the specialty area. So that little tab that says specialty guides, you know, it's segmented out by, you know, cardiology, radiology, podiatry, et cetera, and really worked with the clinical teams to define what are core resources and publications that they want to have available for the clinicians that operate in that particular specialty. Just to give you a sense of size, Geisinger overall has about 30,000 employees, you know, about 2,500 physicians, about 6,000 nurses. The requests we get into the library, as you can see, we get literature searches, we do orientation classes to help folks better use the services we offer, but the bulk is document delivery or interlibrary loan. So, you know, people who are looking for a resource and asking to get help, the library is able to provide very quick turnarounds, which is helpful for our clinician teams. And then the ready reference questions, how do I, where do I get, how does this work? You know, we get all of those types of things that the librarian helps them with. They'll also help with, you know, sometimes there's specific focus in clinical environments. They set up certain materials. We also, this year, started an embedded librarian program where our librarians are going to certain clinical meetings that are talking about patient cases and trying to assist with research and tools that will help the clinical team better solve that particular patient case. We also did some work this year on surveying our users to understand how they were using the library, where did they want to go as part of some strategic planning, and so this is the view from them in terms of how they think they're using the resources. We had responses from about 800 of our clinical folks, so it was great to get that feedback. But they use a lot of electronic table of contents, articles on demand, that's back to that, document delivery. Community health library for our patients ranked up there as well. So just to give you a little bit of a sense of how exactly we're positioned from a library perspective and how those resources are being used. Okay, at this point, there we go. I'm going to transition, and I'm really going to get into the content area that I wanted to talk about today, which is where we're going in trying to personalize our patient approach. And the way you want to think about this is how you experience most of the world. Amazon, hospitality, lots of other services that you interact with from a different industry perspective. And those services are really trying to understand you better and make a personalized experience. There are some hotel chains where you can specify which type of pillow you want. And so when you book the room, they're giving the pillow to you. From a healthcare perspective, we still have a lot of one-size-fits-all modes. We only do things one type of way. Maybe we get some information on the patient, their family, their living style, et cetera, but that's buried in the doctor's note, and it's not available to the finance person or to the scheduling person. And so we really want to leverage some of these tools that are used in other industries to be more personalized. And where this really comes from is, a desire to ensure we're delivering an excellent patient experience. We were very fortunate that at the beginning of the year, our leadership sat down and said, we have a lot of things we want to work on, but there's some areas that we really think are very important. And consumerism actually got named. And again, this is rare for the healthcare industry to really think about customers and tailoring approaches. And so for me and the type of work I do, which involves a lot of patient technology, this was great to hear that we have such a leadership endorsement. All right, to dive into the details. What we're really hoping to do is create an environment where we get to know you at a personal level. And on this slide, we have 3 examples. So one, Betty Smith, she's about 50, has hypertension and diabetes. She uses some technology, and she wants to balance sort of face-to-face with e-visits. She's motivated by knowing what others have done to manage their condition. So as we're working through her care with her, we want to use that information. We want to know that if we're trying to get her to follow a certain care plan, trying to help her with her care decisions, obviously showing what other people in, sort of the baby boomer range are doing, how that's working for them, is going to be effective for them, all right? Not effective for everybody, but for Betty, that's the approach she wants to use. Now, if you go to the next one, we've got Judy, who is the patient. She's 80 years old. She's forgetful. She's not interested in new technologies. She likes to do the face-to-face. Her son is giving her a lot of care. He likes the technology. And so we want to treat them in that way, allow Judy to have her personal relationship with her doctor, understand that she's forgetful, so really involving Tom and keeping him updated is helpful. And then at the end, the last one is Karen Bates, millennial, Lots of kids these days, you know, they barely talk to each other. They're always texting on their phone. I think it's sort of sad. I go to some restaurants and see two people eating together, except they're both on their phones, spending the whole time, and they're not really talking to each other. But, you know, that they are using a technology in different ways, and they have different expectations. So these are just 3 examples. The idea would be to understand the patient's preference, their motivations, their behaviors. It's not a one-size-fits-all. How I work and how my mother work are very different. And if you really want somebody to be successful in their care, they spend a little time with the clinical team, and then the bulk of the time they're out in their home environment, their work environment, their family, friends. And so if we can better understand that and better tailor the situation, we believe that that will help with our overall care. So we want to sort of combine that personal element with the clinical needs of the patient to achieve better outcomes. So the way we think we're going to do this on an enterprise level is using a technology called Customer Relationship Management, or CRM. And so pockets of this occur in the healthcare space. You know, if you're seeing a doctor for a while, they'll get to know you. Maybe they'll get to understand your family situation. They'll understand if you have transportation issues, if you have child care issues, and they'll try and incorporate that. But again, usually it's buried and it's not shared with the broader community. So maybe you have a transportation issue, but the scheduler doesn't actually know that. And so it would be better to schedule you at a time where you had transportation and making sure we understood that. So what we really want to do is to take a system where we can gather all of these pieces of information. Some of it comes directly from the patient, some we learn. We have a lot of data in our electronic medical record, and so we can pipe some of that in and have it in a system that allows us to use this information in all of our interactions. And we want it with our patients, but also our other customers. We have other provider groups we work with. We have health plan members, so it's meant to be a broad vision. And what we've done is we've just done some mapping on all the capabilities we'll need to get this up and running. So this is just an example. It's a pretty big undertaking. With something this big, there's a good bit of cost. There's a significant change in the way that we're doing business, where we really have to, you know, have some quick and easy ways to understand the relevant parts about the person we're talking to. And so we're going to have to make some significant investment in software and in services to run this across the enterprise. And so what we also did was a business case on where we could potentially have benefits. And so they come in a number of areas. Being able to have more appropriate care, being more proactive in a way that is meaningful to the patient, so they come for their visits, they take their medications, and they don't end up in the ED. Being able to attract new customers, making folks more adherent. If you understand why somebody's not taking the medication, you should be in a better position to help develop a plan that will better target their needs. And so, you know, this is where we expect to see some benefits. All right, so how might this all work, and where are we so far? So when we think about this, we're like, you know, this is a pretty big task, but we've actually done some things already that lead us in the direction. So in terms of patient preferences, we do offer a patient portal. It's called mygeisinger.org. And so patients can sign up for that, and they can choose to receive lots of communications electronically. You don't have to, but it's available. We also have a phone system, and we use something called IVR, Interactive Voice Response, where we can leave messages. We can, press 1 for this answer, press 2 for that answer. And so some people prefer to receive information that way. And then we do also offer text messaging for appointments and for a number of clinical programs. So we have some initial starts to build upon. But what we'd want to do is make this a much more robust system that we could take those patient preferences and use them throughout all of our communications. We also have done some steps to allow patients better input into their care. We use patient-reported data in a number of ways where we're really asking the patient about their condition and how they're feeling and their status, how many times they're using their inhaler. You know, if your heart failure, what about your weight, and are you gaining weight too rapidly, blood pressure, seizures, that kind of thing, to help us better target their particular experience with their condition, post-surgery, things like that. We also, a couple of years ago, introduced a program called the Proven Experience Program. This is a program that's about the patient experience and satisfaction. And what we do is we actually offer a refund for the portion that the patient has paid if their experience wasn't a good one. Again, this is something people already do in other industries. You bought a product at Best Buy, it didn't work, you didn't like it, you take it back. You had a lousy stay at your hotel, the staff was rude, your room wasn't clean, you know, the hotel may give you, a future night free. So this happens in other industries, but it's not really been something in healthcare. So something we're pretty proud of to really say we put the patient first. It's not just about making them better. It's about being nice to them, explaining things in a way that's meaningful. We shouldn't be rude. Construction at 2 a.m. may seem logical, but if it keeps the patients up all night in the hospital, that's not achieving their care. Doctor schedules were often made for, they round very early in an inpatient environment. Well, again, at 6 a.m. Might work for the doctor, but is that, do you really want to be waking up a lot of sick patients? They need their sleep, they need their care. So really looking at that type of thing. And we only refund the amount that the patient's paid in, so this doesn't relate to insurance, but co-pays, deductibles type of thing. So again, we feel that that's sort of a start. And we've really been working on, some other tools to let patients do care for themselves. We've been rolling out more and more ability for patients to schedule their own appointments. That's been something that's a little tough. It's been a provider focus to control their schedules a little bit more, and so sort of changing the paradigm and being a little more patient-focused has been tough. Apple is very nice to us in that they create these tools we can leverage, such as iTunes University, which is really something that's more academically focused. You can put up a academic course and all the materials, et cetera. But we looked at it and we said, you know what? It's a way we can distribute a lot of material. So we actually have a program that we've been piloting for lumbar spine surgery, where we post, we have a mobile app, we have videos, we have an electronic book, really a package that allows the patient and their family to be engaged. And again, it's a way that they can easily accessible. And then in April, this past April, we did our website redesign of our main website, geisinger.org, and we also introduced e-visits, which are essentially video visits for some low acuity type conditions for patients who might be interested in having the flexibility of doing something from their home versus going into an office. So when we looked at this personalized approach, we said, okay, we have some starting points, all right, but still lots of work to do, and how do we approach this? So often what we do before starting any program is we actually want to poll our patients and see what they say about what's going on and what they would be interested in. And so that's what we did. And we found out that really what they were interested in varied a lot by the circumstance. So a first visit with a provider is something that folks really wanted to do face-to-face. But after that, there was some more variability in terms of using technology. They are happy to get normal test results over the portal, but if, there's something abnormal, then, a phone call, something more would need to happen. And I think the most interesting thing is we did get some data saying, you know, there was maybe an opening to do a personality test or lifestyle preferences or use past healthcare decisions in their current model to influence how they're cared for. I think the general sense was that if this information would be useful in care treatment, they were very interested in using it. So we've taken this information and we've started to apply it. And one of the first places we've looked at is breast cancer. And the way we choose where we target certain areas is a combination of trying to target a clinically relevant population. You know, the solutions we're putting in are really to solve clinical problems, and the ability to have sponsors and engaged clinical teams. And, you know, some clinical teams are more interested in trying new things than others. So it can naturally work out. So the oncology department was very interested in altering how they approach their patients, getting to a more effective model. So in order for us to learn to do this, we actually did a study with patients about their overall journey and what things are going on in their mind. And so we learned some things that seem straightforward, but you don't often think about it when you're delivering care, that, you know, in the midst of being diagnosed and being treated for breast cancer, they're, of course, thinking about their finances. How much is this going to cost me? Am I going to be out of work? Maybe there's child care issues. How is that going to affect me that way? There's obviously, with breast cancer, a good bit of physical issues. Again, oncology patients, if they're going through chemo, might have hair loss, again, might have mastectomy. How does that relate to their physical appearance? Logistical, how do they get to the appointments? You know, are they going to feel well enough to get to an appointment? Can they take care of their kids? And then all of the emotional and mental conditions that come with that, the anxiety, the guilt, the depression, you know, just the stress that happens. So when you think about wanting to be effective in care, keeping those in mind helps you understand what the patient is going to need. And it's not just about, you know, showing up for their appointment or, you know, getting their regular chemo. There's so much more we could consider to really improve their quality of life and make it easier for them to get better. In addition to some of those concerns, you know, we gathered information that showed us that patients work differently. Again, it's not one size fits all. There's some patients that are very much information seeking. They want all the information they can. They have different decision-making styles. Again, I would argue my mom, who grew up in a generation where the doctor told you what to do, was very comfortable with, you know, following the doctor's advice. I'm much more analytical and questioning. I want the doctor to tell me my 3 options and the pros and cons of each of those. And, you know, I want to be actively involved in the decision. For some patients, privacy is a significant concern. Who's seeing this information? Where is it going to be shared? How much am I going to tell people, et cetera? And then there are varying levels of external support that's available. Some patients have a lot, and some patients are struggling a little bit more. So what we did is we said, okay, let's look at our overall journey, and we engaged one of our partners called Red Privet that helped us with this. And I know you can't read this, but we sort of laid out the various treatment paths that these patients follow. And then what we've been working to do is how can we introduce different options that allow for this personalization across this journey. So that's how we're getting started with breast cancer. In addition, we're tackling another area that relates to diabetes. Again, there's lots of patients who have diabetes, and you know, it's a big epidemic across the country, and lots of clinical protocols. But when you think about diabetes, there are some patients that have diabetes that's really about, you know, hereditary, environmental, other considerations that's hard for them to change. And there are other people that can really impact their diabetes based on their lifestyle. And so when we started to look at this, we looked in a couple of areas in Pennsylvania, in Lackawanna County. And what we found is that, first of all, we have a very high occurrence of diabetes in that area, higher than in the rest of Pennsylvania and higher than in the U.S. overall. And in addition, we have people who have trouble having enough money to buy food. And so they have diabetes. There's a high incidence of what we call food insecurity. They can't buy all the meals they want in this county, again, higher than in Pennsylvania and the United States. And what we also found is there's a high rate of obesity. Now, on initial thought, obesity and food insecurity don't necessarily go together. But if any of you are regular visitors to the grocery store, healthy food is pretty expensive. And so what's happening is these people are buying, canned, processed food with lots of fat because the fruits, the vegetables, the fresh meat is out of their reach. And so for a lot of patients with diabetes, this being overweight really affects their ability to manage the disease. And so we could prescribe the right levels of insulin, we could get them to come back the right number of times to the clinic, but really until we addressed their food situation, it was hard to imagine that we would really make a lot of progress. So we had an initial program called Fresh Food Pharmacy that was for patients with A1C levels over 8 that had food insecurity. And we put together an overall program that included the normal clinical intervention with case management, with pharmacy, with education and nutrition. And we did something where, in addition to their medication prescriptions, we gave them prescriptions for food. And we actually supplied the food. We partnered with a local food bank and grocery store to do this. And we provide food 5 days a week for the patient and their family, because obviously it's very hard for one person in the family to eat certain foods and not the rest. We also partnered with some businesses and foundations and community organizations and Career Technology Center to create a more holistic approach to these patients in the treatment of their diabetes. The initial results for 6 patients that we worked with is by doing this, they had, in a very short period of time, significant drops in their A1C levels of over 200 points. And so that's dramatic. They had significant weight loss, and a number of them actually got to the point where they could reduce or eliminate their medication. So what we showed with this program, if we could be more personalized in understanding what's affecting the patient, we could really do clinical outcome changes. And so this program's been expanded, and we're currently working to involve a lot more patients. We've created a grocery store in our hospital, and so when patients get the prescription, they can go down and get it filled, and continue to partner with community organizations on how to do this. We will shortly be trying out some more technology to help patients manage the situation, recipes, the right food to eat. They attend classes now, doing some of that, offering some of that electronically as well. So those are the places we're going. We've had some starts, learn some information, and so what we're trying to do is really expand this, better pilot this personalized approach, and be able to pilot questions that we're going to ask patients, for example, surveying them about their communication preferences, their learning styles, personality traits, and resource needs. So we've developed some initial types of questionnaires that we're trying out. We're working on trying to get a pilot of the CRM technology up and running so that we can actually see what the tool might be able to do for us, and be able to try it out on a little bit bigger scale. Some of the things we have in mind is that getting people the right views. So this is an example of a view that we might show to a physician or an advanced practitioner treating the patient, where we can really highlight that, Jenny prefers to understand her health in a direct manner. She's motivated to see her grandchildren grow up, so if we put care plans that are based on steps that relate to her grandchildren, that's going to be meaningful for her. But she also has a lot of anxiety when seeing the doctor. She wants to understand her options, but she's also a little forgetful. She is brought to her appointments by her son, so we got to make sure that the son is available. So, you know, when the appointment folks set things up, when the doctor is talking to Jenny about her care, the son needs to be involved. And we want to also, lots of times we're very siloed in the healthcare organization, and the billing person only sees the billing piece, the financial person only sees the financial piece. So we want these views to also reflect other things about the patient. So the doctor is going to see that Jenny also has care gaps around her flu vaccine, colonoscopy, and pap smear, and even though she's coming today maybe to talk about a chronic condition, let's make sure she gets those other things in place. And we can also see that she's had some good experiences, but her recent experiences with the system has not been great, so we need to be cognizant of that. A scheduler would see a view that talks much more about Jenny's preferences as it relates to the types of appointments, when she can make appointments, if she no-shows, you know, on certain days. Again, the fact that transportation with her son is important for them to know, so they can make sure they schedule an appointment when her son is available, and might see more information about, oh, I see you have an outstanding request regarding a billing question, let me take care of that for you. So how can we incorporate all of these elements? So this is the direction we're trying to go. We're looking to broadly expand the communication preferences from where we are now, to change the care delivery approach so that we're really reflecting the preferred style. And we're doing care planning based on the patient-specific goals. Again, tying it into, you know, want to be there for my kid's wedding, want to be there for my grandkids' graduation, want to be able to run a marathon, you know, whatever it is that the person's driving to be able to appeal to that. And also to reflect, you know, certain situations. You know, if there are financial situations, then we've got to be really careful when we're talking about all the treatment options. You know, another test may cause panic with the patient. I think we all care about our money, but, you know, there are those of us who, you know, it's really a financial hardship and may decline care because of that. And so we've got to be cognizant of that, and maybe there's ways we can get help to the patient because we don't want them to avoid care because of that. And then really from a measurement perspective, we're looking at clinical measures. The diabetes, A1C levels, BMI, blood pressure is really helpful for breast cancer. We can look at their symptoms and their care plan over time, and for both of them, how often are they going to the ED or getting readmitted to the hospital or not coming to their appointment. So this is the type of model we're working in to try and see, can we really improve care by being personalized. All right. Next steps, we're going actually through a formal RFP process right now with vendors who provide this technology, and working to get appropriate funding. We have some base level funding for some pilot activity, but also would, you know, trying to get, you know, a bigger set of funds and trying to get a pilot with a tool up and running so we can really demonstrate the value. Okay, so that's the broad overview of, you know, what we're trying to do from a patient personalization perspective. So let me just talk briefly about how the library might be able to impact this type of work, and then we'll turn to questions. So we're just brainstorming a little bit and working with my library team, but I think from a library perspective, this personalized approach really focuses and highlights the need to be cognizant of health literacy. And again, I think as librarians, you guys all know that, but it's not something that's regularly incorporated into clinical care. The language we use from a clinical team perspective, you know, needs to be tailored to the patient. I remember I took my husband into our local ED, and he ended up having kidney stones, and one person came in to say he had to have a procedure done to remove them. And she came in and she said something, but I didn't understand a word of what she said. It was like she was speaking another language because she was using all very specific clinical terminology. Now, I even work in the healthcare environment, and I was looking at her. And then she paused and she said, he's here for the kidney stone procedure. And I'm like, yes. I have no idea what you just said otherwise, but kidney stone is what I'm looking for. So we really need to be cognizant of our patients and really tailor their approach. We do have patients that you can have a much more sophisticated, higher reading level approach, and some that need, you know, the 6th grade reading level. I think we definitely here at Geisinger need to increase the awareness among our clinical team about how librarians can assist. We're getting a lot of requests, but there's more we can do. We can really help the clinical teams provide the needed information to their patient, to give them information on appropriate research, et cetera, to really enable this approach. We can help the clinical teams from a library perspective to incorporate patient-specific goals. Again, I think a lot of library work is tailored to the type of person you're dealing with, and so helping the clinical teams reach that. And then not everybody in the clinical community really understands the value of patient engagement, really understands the value of the family involvement and being tailored. And so there's lots of research out there on this, and so helping to educate our clinical teams would be helpful as well. So you guys probably have lots of other ideas, but those are just some that, you know, we brainstormed on in terms of integrating the library into some of this business functionality. All right, with that, I think we're ready to move on to questions. And so I will look in the chat window, but feel free to go ahead and type those in and look on that. So the first one I think is Fresh Food Pharmacy. So I guess this is just a clarification. So I didn't actually put the A1C levels. So these folks had A1C levels in the 300 to 400 ranges. So, you know, we were trying to, you know, drop that. That's where the 200 points coming in. All right, are there other questions that folks have?
Hi, Shannon. I just had a question come in. Does the Geisinger Library work financially on the per patient day model? How is it funded?
So the library is funded at the system level. So it has an independent budget that allocates resources for the staffing, for books, periodicals, journals, tools like Isabel, Up to Date, Clinical Key, those types of things. I have Tricia Ulmer in my office with me, who's one of our librarians. So those are all funded at an organization-wide level, and we work to make those tools available to everyone across the system. You know, sometimes it can be a little challenging to work with the different vendors based on the models of how they want to charge you. So you guys, again, I think are very familiar with that. You know, the library's been around for a while, and once budgets get established, they usually perpetuate. We do occasionally have to go and argue for some additional resource. I think with the integration we're doing with the School of Medicine, there'll be a different budget discussion this year, but that's how we do library funding at the moment.
There's a follow-up from the same person, and maybe you answered that a little bit. But how did you negotiate that independent model? And she would also be interested in learning more about that to helping with her own healthcare system.
So I don't think Tricia and I were around when that was done. It's been in place for a long time. So unfortunately, we don't have any recent experience. It is the model at Geisinger for enterprise services to really be taken at that higher level, we use a cost allocation system. So the clinical teams have to do their revenue and cost separately, and they're really matching that. And then there are common functions like our revenue management function, our IT function, library function that are at a system level. And what's done is those costs are combined and they're allocated back to the revenue producing unit through a cost allocation system. And the cost allocation system, quite honestly, is very complex. Sometimes it's based on number of providers. Sometimes it's based on number of desktops, hospital platforms. I need the finance person to explain it, but there's different categories where they spread out this cost.
Great, thank you. I think we have time for at least one more question. If anyone has something, go ahead and type it into the chat box.
All right, I think there was, some questions in terms of the overall division of informatics and, in general, rural Pennsylvania. So the division of informatics is a system-wide group, again, that focuses on how we can use technology and data and information to improve healthcare. So we have several groups within the division. We have a pretty significant business intelligence and data analytics capability. We are a data-driven system. We take data from the EMR, from other clinical systems, from health information exchanges, from claim systems, et cetera. And so we can run analysis on what patients with abnormal mammograms have not been seen. We did a study around aneurysms and patients, sort of the conditions that lead up to having what's called a AAA, and we're able to find a number of patients that were highly at risk and reach out to them and get them into better care. So we do a lot with that. We have my team, in addition to the library, which is called Geisinger Motion, which is all about mobile technology, what Brian really focused on in his introduction, patient portals, text messaging, mobile apps. How can we use that type of technology to better engage the patient and to make the job of the provider easier as they're running around the hospital and trying to get connected with folks. And then we have a team of physicians called physician informaticians. These are practicing physicians, but they spend a portion of their time working with our group and with IT to ensure that the clinical decisions that we use are relevant, that we're integrating appropriately into clinical workflows, et cetera. Central Pennsylvania is very rural. The area we operate in, Pennsylvania, essentially it has Pittsburgh on one end and Philadelphia on the other. The east, we have some more population in the Scranton, Wilkes-Barre area, but there's a lot of space in between of towns that are 3,000 to 5,000 folks. So it is a very rural community. We still have a large manufacturing base. We have a lot of obesity. A very significant condition in our area with patients. We also have a lot of stability. So patients who live here and their family lives here and grandparents, et cetera. So we do some work with genomics where we can really trace some things because we have such a long lineage. We do have still, a quarter to a third of the population that's accessing the internet from dial-in type of capability, which just seems crazy to me. So we do need to, make sure we're honoring preference, and not everybody's going to want that technology. And again, a higher manufacturing base again makes that health literacy question extremely important.
Great. Well, thank you for speaking with us today, Shannon, and thank you for the wonderful presentation. I think there are a lot of opportunities and ideas and insights for us to all mull over. So it's a pleasure to have you with us. I'm now going to go ahead and stop the recording before a few final housekeeping items.